Annie, bonjour. Welcome back, everyone. I'm finding this to be a really phenomenal day so far with a lot of rich learnings, and I hope that you are experiencing the same. My name is Sonia Shang. I'm privileged to be joining from the lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples in now Toronto. And I'm the director of the Canadian Institute for Social Prescribing, or CISP for short, which is a new initiative anchored within the Canadian Red Cross with funding from the Public Health Agency of Canada. CISP is a national hub where we hope to connect people, practices, projects, and research on social prescribing across different sectors and regions together under one big network to learn from each other, to collaborate, and to celebrate what everyone is doing. At the same time, we are intentionally bringing together key stakeholders across Canada to co-create a national framework for social prescribing that has shared principles, languages, and values while being adaptable to the unique contexts and assets of each community. Social prescribing now has global recognition. More than 20 countries worldwide are adopting the terminology and practice in sectors from primary care, secondary, rehabilitation, acute care, home care, and of course in the community sectors. And in Canada, there are a number of social prescribing initiatives being implemented in different regions. You have and will continue to hear about the amazing work in Ontario today. At the same time, there are growing and emergent practices from British Columbia all the way to the Atlantic provinces. So I am so thrilled to have this panel of amazing leaders for a virtual fireside chat on what is happening in British Columbia, Alberta, Manitoba, and Quebec. So we will hear from Bobby Symes, the Assistant Director of Healthy Aging at United Way, British Columbia, Lisa Stebbins, Chief Program Officer at CARIA in Calgary and a member of Community Leadership Team with Healthy Aging Alberta, Connie Newman, Executive Director of the Manitoba Association of Senior Communities, and Paula Leal, Project Manager at the Eva Marston Center for Social Justice and Aging in Montreal. So to start us off, what does social prescribing look like in your provinces? Let's go from west to east. So over to you first, Bobby.
Hi, everyone. So happy to be here today. My name is Bobby Symes. I'm the Assistant Director of Healthy Aging at United Way, British Columbia. In BC, just like all the other provinces, the concept or notion of social prescribing has been around for years. Doctors establishing relationships with community organizations, those organizations in turn providing social supports for the people in their community. It's been going on for a long time. However, it became more formalized with the growing movement in around 2019. And I'll speak on behalf of what United Way BC is involved in, although there are other communities throughout BC who are also doing this work. Through the communities, consultations, and our Healthy Aging Summit, we heard from our network of community-based senior serving organizations that we needed a better way to reach out to isolated seniors. These agencies needed a better way. These agencies knew of the seniors that were coming into their programs, but they also knew that there were others, especially isolated seniors, that could also benefit from the supports that they could provide. They just didn't know how to reach out to them. So we started looking at other countries, what they were doing, and we learned of the social prescribing model in the UK. And a few members from our team traveled to the UK to attend the social prescribing conference, and we learned a lot more about it. From there, we brought the idea back to our leadership council, and we were able to support and funding from the Ministry of Health for a 3-year demonstration project for 19 programs across BC. These programs are to support old, especially because programs are based within the community organizations. So community centers, neighborhood houses, senior centers that already have established relationships, programs, and experience working with seniors. The funding provided was for a community connector position in each of those 19 communities. Thanks, Sonia.
Thanks so much, Bobby. I think next province would be Alberta. Over to you, Lisa.
Thanks, Sonia. So the journey for social prescribing in Alberta is new and has been really intertwined with our work in enhancing non-medical and in-home supports across the province. And the work has been co-created with support from the Alberta Ministry of Seniors and Housing and key sponsors across government ministries. The provincial government has already made an initial short-term investment for community-based home support that has been facilitated through Healthy Aging Alberta, as well as more targeted investments in the social prescribing space to advance this concept in Alberta. One of these projects has been funded for my organization, CARIA, and our work with the Way In Network, a collaborative of 4 agencies in Calgary. The Aging and Community Supports project has been underway since the fall of 2020 with seed funding from the Government of Alberta, the United Way of Calgary and area, Alberta Health Services, and now a $1 million investment from Alberta's Ministry of Health to continue the project to 2024. And the project includes 4 full-time social worker positions that we call outreach workers, focused on building referral pathways, creating service plans, and supporting individuals in connecting to resources that support their well-being and healthy aging in community. We have 2 full-time independent living support positions that have been added in 2022 to assist the participants with tasks they may struggle with independently. We also are able, with this funding, to increase an additional 1.5 full-time outreach worker positions in the 2023-24 funding period. And we've currently established referral pathways in all 4 primary care networks in Calgary. We have beginning connections with acute care sites and health organizations that support diverse populations. There are an additional 2 regional projects underway in the province at different levels of readiness, each with a unique approach that meet their local context. Inspired by BC's approach, we've also created a provincial community of practice model that all 3 current projects participate in, and it aims to standardize approaches and terminology, learn from each other, and promote shared outcome measurements. And then with an additional funding from an anonymous donor over the next 3 years, the 3 existing projects will be further supported, and an additional 3 projects will be funded in phase 2 of the project. So that's kind of where we're at here in Alberta.
Thank you, Lisa. Lots of exciting developments. Connie, what's happening in Manitoba?
If I use the word social prescribing, I'd say nothing. If I use the word social participation as a part of age-friendly, I'd say lots. The Manitoba Association of Senior Communities, we have 2 lines of business: seniors centers, community centers, and age-friendly communities. There, as an association, we have 71 member organizations throughout Manitoba. More than half of these centers are partially funded through Manitoba Health at the regional level. We also have a connection on the ground with the senior support coordinators who are funded by Manitoba Health as well. That funding goes to a nonprofit board of directors who hire what I'm going to use the word the linkages in the local community. They are the frontline workers, generally on a 1-to-1 at the community level. They are finders of services to assist the older adult in staying in their own home as long as possible. We also connect with over 100 municipalities who are on the age-friendly pathway. We have an age-friendly team. There's 5 of them who have been around connecting with 18 communities, each of them, over the last 4 or 5 years. We do an age-friendly newsletter once a month. Today, social prescribing, thanks to a private donor, will become another line of business to connect our centers, primary health care, and our age-friendly team. We are brand new to social prescribing. We have been thinking about it for many months and are now new to the movement and quite enjoying what I'm hearing across Canada. Our current infrastructure will enable us to expand our lines of business and include a third group, our primary health care. At the local level, we have primary health care teams. We also have My Health teams who we are going to attempt to connect at the local level. We're looking forward to including social participation with primary health at the local level. We're proposing top-down, bottom-up approach, and we're moving forward. Thank you.
Thank you, Connie. Welcome to the movement of social prescribing. Paula, last but not least, Montreal, what is happening there?
Well, in our province, social prescribing has been a passion project from my boss, Sherry McLeod from the Eva Marson Center, and Stephanie Dupont from the CISP. And through lots of ups and downs, we finally managed to arrive at a point, despite the pandemic, where social prescribing is now at its early stages. So from that, we've been able or have had the funding and actually the support from many people to be able to create a website that encompasses community organizations, resources, and service throughout the west of Montreal. And that resource, we believe and hope, will allow to do a systematic follow-up and be able to highlight all the services that are available throughout each boroughs of that section of Montreal. So again, through word of mouth, we gained along the way lots of interest from universities, from community organizations, and finally, we also gained a bit more support from the CISP, which is the Quebec's Institution of Health and Social Services. And as of this month, we are currently doing focus groups, both in the community organizations and government institutions, in order to evaluate the needs of our community organization, of the CISP, of our current system of care, actually. And that way, we wish to know how we can integrate social prescribing in the west of Montreal to reflect the need that we currently have. So of course, we hope that our way of social prescribing will allow to have a better communication between all of our sectors and create a network to help people that are in need and that might fall through the cracks. So that's basically where we're at. Hopefully we'll get along further along this year, but that's up to grabs, I guess.
Thank you, Paula. For Bobby and Lisa, I think the social prescribing work, particularly in BC, has been ongoing for a few years now and it's quite mature. So for Bobby, what is the impact that you are seeing now with your social prescribing initiatives? Thanks,
Sonia. Well, we're in the final few months of our demonstration project, which started in January of 2020. And as you can imagine, there have been hiccups along the way to measure the impact of the programs during a global pandemic, especially ones that have started just as we were getting hit. But also in terms of timing, we were lucky to have these 19 dedicated professionals to reach out to older adults during the pandemic. Basic needs like grocery shopping, wellness calls, prescription pickup, and delivery, transportation, and medical appointments were just some of the basic necessities that the connectors supported in the first year or so due to COVID-19. And in many cases, the connectors were the lifeline for these seniors during this unprecedented time. Our evaluation of the demonstration project has taken a bit of a turn. We are now focusing on more of the qualitative impact, including stories from staff, seniors, volunteers, and family members. We were originally hoping to look at things like reduced GP visits, emergency room stays and visits, and quality of life, but COVID kind of threw a bit of a wrench at us there. But we're still hoping to capture that as we move forward. Our evaluation goes through to the end of this year, and a report is expected in March of 2023. But the impact is undeniable. I mean, we meet monthly, as Lisa had said, as a community of practice with our community connectors, and each month someone is selected to share a story, a learning, or a lesson, something that made them feel good or something that they're struggling with that the community of practice can support. And I have to say that we've cheered them on as they broke barriers with their participants, and we've cried with them when they've lost someone. And I just wanted to recall a story of Roger that I'll share with the group. Roger had just recently retired and found that he was stuck in an unhealthy behavioral patterns. He expressed to his GP that he would like to make changes and was referred to the community connector in his area. And Roger had struggled with mental health for most of his life, and he never had able to get support for it. And he had said that he had been referred to mental health services by his GP in the past, but they said that the service was for people with substance use issues along with mental health. And while Roger used alcohol and cannabis to manage his depression, he never identified as an addict, and therefore he didn't qualify for support. Roger was an intelligent, hardworking man. He had a long, successful marriage. He made good money. He had friends and family who loved him, nieces and nephews that he spent time with, and he continued to struggle with depression and anxiety and a self-destructive coping strategies through his life. He described his early childhood experiences. He endured a lot of trauma from a young age and into adulthood. Roger expressed that he had used alcohol to help cope with his depression and his anxiety. He was making an effort to cut back, but always seemed to drink more than he wanted to. He hooked up with the community connector, and she supported Roger to identify some goals and to break them down into SMART goals and working one at a time so he didn't feel overwhelmed. Within 3 months of working with the community connector, Roger had created a routine of daily exercise. He joined a local rec center. He started playing pickleball and attended aquasize classes twice a week, even though he was the youngest and the only male in the class. The connector and Roger reviewed a list of psychologists and counselors in the area, and he chose 3 that he wanted to try. Roger met with all 3 and chose one that he was comfortable with. And Roger participated in the social prescribing program with his connector for 3 months and was successful in meeting all of his goals. He was a self-motivated individual, and all he really needed was support in identifying his goals, breaking them down so he could do one step at a time, having someone to be accountable to. And I think one of the most important aspects of the social prescribing program is that participants like Roger have someone to listen to them. Today, Roger is doing well, has significantly cut down on his drinking. He's meeting his psychologist that he likes, and he continues to exercise daily and loves pickleball and the new friends that he's made. Thanks, Sonia.
Thanks, Bobby. That's fantastic. Thank you for sharing that story. And I feel like I should pick up pickleball now. Lisa, the work in Alberta is newer, as you mentioned, but there is a lot of existing work in which the new work is based on and building together. Can you speak to some of the impact that you've seen?
Yeah, absolutely, Sonia. So the 3 current projects are at different phases of readiness, but I can report the Weigh-In Network's Aging and Community Supports projects received, since 2020, received 527 referrals with 484 intakes into the program to date. And as I mentioned, there's a strong correlation between the development of our in-home support or non-medical supports and social prescribing. Of course, you need programs to prescribe to in order to have a social prescribing. So there's some work going on in both those arenas. Impacts have ranged from enhancing the quality of life by connecting low-income seniors to benefits and income support, supported referrals to in-home supports like homemaking, snow and mow, grocery shopping, friendly visiting, and essential transportation, stabilization of housing, supported referrals to social connection programming, supported referrals to mental health supports, and interface or connection with the primary care network to support their health needs. And so very similar to Bobby's story, I use the term supported referrals to describe a more hands-on approach to assisting individuals to access supports, which may include making phone calls together, assisting with applications, or accompanying individuals to programs or appointments while they gain their confidence around some of the resources they want to access. But we've also had outcomes that have resulted in supporting individuals to other levels of care in supportive living situations. So one individual had 52 hospital admissions related to falls in less than a year. Every time they were admitted, they were on a different unit in the hospital with different staff, a different doctor, a different social worker, a nurse, perhaps a different nurse navigator. and there was no coordination or further exploration of what could be going on for this person. And so finally, they were referred to our social prescribing project with the support of an outreach worker. They gradually built trust and learned they were scared of losing independence, but their living situation was no longer suitable to their increased health needs. And so the worker arranged for a day pass from hospital and took them on a tour of a supportive living site that met their needs. And they worked with them to adjust to the concept and supported all the pieces to get them moved in. And they're now happily and safely living in a care environment that met their needs, and their quality of life has improved drastically. And without that, there would have continued to be a cycle of hospital admittances. And I'm happy to report that there hasn't been any hospital admittances since he's received that additional support and transition for almost a year now. So although our primary focus is around aging in community, sometimes people need support to get to the right environment, and they need that helping hand to do that and break down, as Bobby said, break down the situation, set goals, and help them towards achieving those.
Thank you, Lisa. And what a beautiful example of a different entryway into social prescribing but supporting still on that holistic spectrum of need. For Paula and Connie, the work that is happening in your regions are earlier stage. Can you speak a bit more to why you embarked on this? What are you hoping to achieve when you look forward in your project? What do you hope social prescribing will do?
Me first?
Sure, go ahead, Connie.
As I listen to both Bobby and Lisa, and I think about some of the stuff we're already doing in Manitoba, we MASC are involved with Older Winnipeggers Social Engagement Project. It's a team of 5 different provincial organizations focusing on low-income seniors in Winnipeg. So the connector, the linkage, the knowledge that we have to share with older adults is paramount on all of this. Have we called it social prescribing? No. Will we going forward? Absolutely. We find here in Manitoba, we the nonprofits are connecting very, very well through senior centers and the linkages at the community level. Now we need to bring the health piece into our fold, because social participation, social prescribing, I'm hearing it. We've got situations in Winnipeg where an older adult's calling paramedics on a regular basis because in this case, she wanted somebody to talk to. So going forward, for me, for us, is to look at municipal services, family doctors, making sure they're aware of all the supports they have next door in their community so that they can help us connect to existing supports that we already have. I believe we've got the infrastructure there. We just have to bring that third pillar into our infrastructure. So I'm hearing a lot of good things today. Thank you.
Thank you, Connie. That intentional collaboration is definitely a common thread that I hear, and that is so key to supporting a well-being of the whole community. Paula, what are your thoughts on what you are hoping to achieve in Montreal?
Oh, sorry, I hope you can't hear the truck outside my window, but to be honest, we went in an approach slightly different than the other province. We are not targeting specifically aging population. We're targeting anybody that needs help, that needs any sort of social determinants to support. Hopefully that's clear. And our situation down in Quebec is a lot of community organizations, and our health system is sort of a one-man island. And that's not what we want. We wish that social prescribing becomes this sort of bridge that can gap all of the issues. Perhaps it might not be a solve-all, but maybe that can be an entryway to exactly solve this sort of gap we can see, bridge something between the community organization and our healthcare care system. We would like it to become a more cohesive system of care. So we're dealing with culture of change, a new kind of way of caring. So we really want community or organization, first and foremost, to learn to lean on each other, to share their expertise, to share any problems they have. That would be one goal of this. And we really hope this could create this through the social prescribing model. We really also want to dismantle this whole notion that we're all in it for our own existence, of our own existence of community organization is what I mean. And we really would like it to become, we can help each other without us feeling kind of threatened or competitive to go through fundings, because this is our situation. We all have to deal with, we must fund our own projects and we have to ensure survival. But if we work together, maybe we wouldn't need that kind of mentality. But that's maybe a pipe dream, but hopefully social prescribing could help with this. And so we also want social prescribing to become or create an awareness on all the services that are already implemented in the communities. There are some wonderful organizations down there that are doing great jobs. And we want them to have that platform to get this recognition from other community organizations. So yeah, in long way to say, we really want a culture of change in our system of care.
I love that, Paula. And I think I hear consistently throughout today in what you say and also in the sessions prior, at the core, social prescribing is relationship building. And social prescribing is around building that relationship and the trust with participants and also within systems. And so that's something that I personally am very keen about and would love to see in our work together. Connie, did you have a response to Paula?
It's not a response, it's to add on, and I'm very much in agreement, because over the past few years, that whole aspect of collaboration amongst what I'm going to call the nonprofit sector has been huge. And we're all, and COVID did it to all of us, that isolation, no matter what age, we all need to be working together for the mental health of all, including what I'm going to call the healthcare system.
Absolutely beautifully said, Connie. We're going to move to participant questions shortly, but as we ask our panel questions, the last prepared question, please share with us, in the chat, what opportunities you are involved in or are seeing in the regions, provinces, and territories that we haven't talked about. So as you do that for our panelists, can you tell me in just one or two sentences, how do you hope to see social prescribing evolve in Canada over the next 3 years? Where do you see it going? And this time we'll go the opposite way. We'll go from the East Coast to the West. So Paula, over to you.
Right, to reiterate, we really wish to have this systematic change in our healthcare system, in our organization. We hope that we have this better communication. We have this integrated system of referrals and follow-up already there. And hopefully we get more funding through Canada to show this movement. And I hope we can learn and adapt our own model so that it responds to the reality of all culture, of all the needs of community organization, of the CISP, and of course of the people that are going to be benefiting from these services. So there you go. That's what I really wish. Let's see if it happens.
Thank you, Paula. That I appreciate that. Big vision. I think we can do it. Connie?
I sure hope we can do it. And I'm glad you're doing what you're doing, Sonia. In Manitoba, we are going to start small in the next 12 months because we believe success breeds success. And if I can get the healthcare system in 4 to 5 communities to be working with their existing infrastructure, we're on our way. It works in one community in Manitoba, it should work in other similar communities. We've got a distance problem, travel problem. We've also got a Wi-Fi internet, as we all know, in terms of connections. We shall overcome. In Winnipeg, we're going to start with 2 neighborhoods or districts and move into others in the next few years. In 4 years, the silos are gone and Manitoba becomes person-centered, not system-centered. There is collaboration, partnerships between healthcare, which is a provincial responsibility, and recreation, which is a municipal responsibility. And that's a tall order. Here's hoping. Thank you.
Connie, that is fantastic. Beautiful. Lisa.
I agree totally with Paula and Connie. For sure want to see those things. In Alberta, we definitely want to see population level change with at least 6 projects implemented in the province over the next 3 years. We're working very hard to demonstrate to the health sector the value of in-home supports and non-medical supports, as well as social prescribing, and trying to do that through shared measurement and collective impact, but also demonstrating cost savings to the health system when you pay attention to those social determinants of health and supporting individuals in those other areas. I think we'd like to see some standardized elements such as assessment and service planning and an evaluation, but we still want to support unique approaches based on regional needs and regional context. And as everyone else has said, sustainable investments in in-home supports, non-medical support, social prescribing is definitely an outcome we want to see as we build the case for support for this work.
Thank you, Lisa. Bobby?
Thanks, Sonia. Well, right now here in BC, we've got a demonstration project that receives dedicated funding from the Ministry of Health. My hope is that we'll be able to show the success of the program through the evaluation and make a case to continue into the future. With that, BC can help make the case to expand social prescribing in both BC, but also other provinces. Canada is seen, not that they aren't now, but seen as a strong leader in this area. In the creation of CISP, collaborations that we're seeing at events like this one today, I think it appears that we're moving in the right direction. But if I can echo what others have said, if I were to move beyond those 3 years and think pie in the sky, I guess it would be that social prescribing wasn't a program offered by an organization, but rather the way in which we provide care to people in the community. That it becomes normal for a doctor to ask questions like, what makes you happy, instead of what seems to be the problem. That we didn't have to use terms like social prescribing because the process was understood and embedded in how we provide care.
Beautiful. Thank you, Bobby, and all of you for just the vision that you have and the passion that is very apparent in the work that you do. We have a few questions that has come in. Please continue to pop them in the Q&A or in the chat. We will have actually got quite a bit of time for this. So the first question is over to Lisa. In a fiscally conservative province, how is Alberta able to advocate to get the level of funding that you have?
Oh, we had to go to politics, did we? I guess. I think the approach we've been taking is really demonstrating how investments in this area take away from costs in other areas. So in this case, mostly the health system. So people are going to hospital and emergency room visits because they're not getting their social or non-medical needs met. And it's taking tremendous resources from an already constrained environment. to do that. And so really demonstrating how this work can prevent those hospitalizations and emergency visits. Of course, there's all kinds of complications around sharing medical data and that sort of thing. And so we're kind of using a more of a self-reporting method of tracking emergency visits and hospitalizations, but hopefully being able to move to a more integrated way of showing that measurement within the health data system to do that. And so I feel the government has been very supportive to date around looking at this as part of the solution for a stronger and better health system that's more holistic and can meet people's needs where they're at.
Thank you, Lisa. So following up on that, they invite all of you to, I think particularly Bobby, to share around the data infrastructure for evaluation in your initiative.
Sure. We were quite intentional right at the outset because we had the evaluation framework and we were looking at research around hospitalization and health utilization. And so when we first launched these programs, we did it we actually created a database called iUnite, where programs could use it for participant intake and service delivery. And we embedded the evaluation questions in intake. Now, that makes an intake quite robust and very long. You know, we practice some motivational interviewing techniques with our program coordinators. But we felt it was better with the program coordinators asking these research type questions than it was to bring in a research team or evaluation team later on, because they didn't have that established relationship with those individuals. And so we asked questions about rating quality of life. We even asked if they would release their personal health number, because that was a way to look at hospitalization and GP visits over time. Now, of course, there was consent in place, and you know, they often didn't give it right at the outset, but as you build relationship and trust over time and seeing the benefits of the program, then they were more welcome to, or felt more comfortable releasing things like PHNs. But we did intentionally we invested in a database that all of our programs were trained in, and they used that, like I said, for the intake and service delivery. So all of that was embedded. And then when the evaluation, we could just pull and export that raw data and give it to our evaluation team.
Other comments on evaluation and data capturing from the other presenters? Lisa?
Yeah, I think Bobby touched on some of the dynamics in measuring this work. And so we too were on a little bit of a journey around, we originally had external people following up and collecting survey data, but they hadn't built that relationship and we weren't getting the richness of information that we needed. So using the staff in a way that works well with collecting that information. And I think as you've seen today and probably in other presentations, the participant journey and storytelling is a very valuable component to showing the value of this work. And so some investments and focus on storytelling and collecting the journeys, I think, is also an important aspect of the evaluation process.
Absolutely. I think broadly, I would say that that's something that we all recognize as important and is a need. There are, operationally a lot of challenges in terms of implementing common data structure outside of the individual projects and programs. And how do we connect? How do you follow the client journey between healthcare and community support and all of that work? I know that there is good work happening in Ontario around the integration to the EMR. So I think those are things that will get us to the next step, the things that we are exploring together. There is a specific questions around social prescribing with seniors living with mental health and addictions related challenges. So what are some, do you have experience with this? What are some of the challenges And particularly for Lisa, can you comment on Twin's social prescribing work? I'm not familiar with that program, but perhaps you are.
Yeah, the Way In network, I think, is what they're the Twin is what it's referring to. So we are seeing a lot of our participants that are experiencing mental health concerns or addictions concerns, and our project definitely was funded to support people that were at risk for mental health and addictions issues. And so I think some of the challenges in doing that is you have to work with individuals throughout their journey. And so I know one of our participants, you know, every time we came for a community visit, maybe wasn't sober or could have a conversation around what some goals would be and that sort of thing. So really that persistence in building the trust and building a relationship is really key in that regard. And I think the community-based sector making those referrals and supporting those referrals and not the health system doing it does allow for sometimes a better buy-in to those resources. You know, the stigma of mental health and people walking into, you know, a hospital mental health facility, it is not always a positive experience. And so working from a community perspective and knowing those resources that are available in community is definitely an asset in working with individuals that are experiencing mental health and addictions. I don't know if I captured it.
Thank you, Lisa. Anyone wish to add to what Lisa has said? Well, building on that, oh, sorry, Connie, go ahead.
I guess a short ad. We encourage here through our senior centers, our community centers, to be welcoming and open to all. We're in a society, more so in the last 3-4 years, a smile at the door goes a long way. So that first thing that an older person, whether coming with mental health issues or whatever baggage, we need to be open and welcoming to those. And it's something we push on a regular basis here.
Thank you, Connie. Well, building on that, can you, for all of you, how are you intentionally building in that equity lens, that support, removing barriers for marginalized populations in the work that you do, or the programs that you are building? Go ahead, Connie.
Part of it comes from our provincial networks. We have a Manitoba Seniors Coalition, and our active aging partner has connected with several of our marginalized groups through physical activity or the 55+ games, and that has opened the door, continuing collaboration across cultural groups. Just by being present, by being listening, the Active Aging in Manitoba group has opened up the doors to several marginalized groups. Through our other older Winnipeg social engagement project, the same thing has happened there, where we literally went out and approached some perceived marginalized groups and brought them into the fold to be part of us. So that's what's happening here.
Thank you, Connie. Bobby, Paul, Lisa.
I can add too. So at the beginning of the project, we really focused on primary care networks and trying to also get support from the acute care sites. But we realized after you know, a year and a half into the project, that we were probably missing populations by looking at those bigger systems as referral pathways. And so we're doing some work now in developing referral pathways from those more unique, diverse organizations like that. You know, we have a Punjabi Health Center, Indigenous Health Services, both in urban settings and the surrounding areas, and looking at what those referral pathways could look like. And also, you know, the learning both ways around what some of the community resources would be in those settings, and our experience in social prescribing and what we found. And so kind of being allies to each other in that work and partnership. So that we've just started over the summer, making some efforts to build those connections and pathways.
Thanks, Lisa. Bobby, I think you had some comments.
I was going to say something very similar to what Lisa did. It's about intentionally establishing those partnerships with organizations that do this well. So having those multi-language organizations, ensuring that, you know, culture is there for people that, you know, need it. We've funded specifically, you know, a Japanese program, you know, that have cultural specific programs for the Japanese people in their community. We've partnered with organizations like Wavefront, which is for the deaf and hard of hearing. And so it's reaching out and making sure that the people that are coming into those programs, we're meeting them where they're at. And we've got partnerships established to ensure that.
Thank you, Bobby. Anything further to add, Paula?
I mean, it's similar and dissimilar in our end, as our project is really a compendium of all the resources already existing. So there are already organizations that are doing great jobs to their specific population. But if we're to integrate this and make a referral pathway that actually works, we'll need to have their support and have their opinion how our model could work with them, and to have this concrete and solid way of, for example, if we're referring from two different organizations where one has a marginalized group that they have no idea how to help, that the referral would be done correctly to the correct organization. So that's something we have to work along further down the line, because right now our battle is really having the support from both sides of the system. So yes, this is something we're very aware of, and our own prescription, which again is a platform that can also print out paper that says what resources you need and some keynotes that you need to know to help that person, should also allow to have this written in their own language if they need so, for example. So all aware of that, this is something we would have to work on, and funding, of course.
Thank you, Paula. Continuing along the thread, there's two questions I'm going to combine along this thread of collaboration and equity. Are you working with 211? And which I know the answer, I see lots of nods immediately. And any specific programs or initiatives you can point to that is working with the 2S LGBTQ+ community? And newcomers, refugees, or people on asylum?
Sure. We just, the newcomer, not the rainbow group. That's the term we use here because I don't get all those letters all the time. They are part of our infrastructure, and we meet with them and we bring them to our community connecting hubs. We do about 4 a year in the localized community already. So they are part of, have we talked about social prescribing with them? Not yet, but that's part of the pathway we're moving forward on.
Thank you, Connie. Third thought, Bobby.
Yeah, I'll just speak to it a little bit because, you know, although it's not intentional, because we've created relationships with many different groups in many different communities, it's there and it's embedded.
Yeah.
And so we actually have, it's interestingly enough, we have community connectors who are from the LGBT community. We have community connectors who specialize in refugee or cultural programs. And within our communities of practice, this is where the sharing of the knowledge comes across. And so if a community connector is supporting somebody from the LGBT community, they feel safe to ask questions within that community practice to another community connector who has links and partnerships already. And so they're sharing across.
Thank you, Bobby. Any quick notes around caregivers and the work with caregiving and caregivers, either as the participant themselves or as a part of the circle of care of the person? Lisa.
Yeah, absolutely. Although a large group of the participants have very few natural supports, and so that a lot of the support we're providing, it might be support that would have come from natural supports in other instances. But we do have participants that do have people in their lives that are supporting them in different ways. And so we find that we would also, as part of our conversations, and if the caregiver is involved, then we're also connecting them to resources. Sometimes they're having similar struggles, like they might have addictions as well. And so we're also supporting the initial participant that came referred, but the people that are in their lives and supporting them and getting them connected to the resources as well. So yeah, for sure, we will work with the participant and the natural supports that are supporting them in their community.
Thank you, Lisa. And I do know that there is work and focus, and particularly from a lot of learnings from our UK colleagues around supporting the caregivers with social prescriptions, recognizing that that's a heavy care burden with particularly family and informal caregivers. I think Bobby and Connie, I think there's lots to be said. Okay, rapid fire, Connie and then Bobby.
We launched in the spring through our age-friendly work, dementia-friendly communities as part of that, taking care of caregivers, because a community, no matter how big or how small, needs to acknowledge that people with dementia are living in community much longer than they did. And we have to be welcoming to the caregivers and supporting them. And sometimes it's very simple support, which makes the caregiver feel included. So we're on that path already.
Beautiful, thanks, Connie. Bobby.
And just to echo what Connie said, knowing if we're going to promote programs to keep seniors at home and in community longer, you have to support the caregivers that are there right alongside of them. United Way actually has a funded family and friend caregiver program with the backbone support of Family Caregivers of BC. And that program is being evaluated right alongside our social prescribing program. And so these two different programs, they share information and resources across. So yeah, I just wanted to say, I think that the caregiver side is extremely important. And we, in one of our regions, we actually have partnered with Home Community Care, where the case manager, when she goes in to do the first assessment with a home care client, that she will actually share resources about social prescribing and caregiving at the same time. So she's starting to use these, talk about these programs right at that home care level, which has been pretty amazing.
Amazing, thank you, Bobby. I see a question around advice for primary care providers. I believe there is a session coming up that is around clinicians that's focused on that. So please attend that one. I think that you will, that will be very valuable for all of us. I'm also, before we lob up next to Jordanos for some of her closing remarks, I want to start off with a comment from one of our UK colleagues who said that maybe cost savings is not what we should focus on. Perhaps once people are better connected, there might be an increase in cost in the short term, especially But what is important is engaging people more robustly and coherently. So that's a really great thought, and we'll carry that as we pass this to Jordanos Waldermarin, Manager of Design Strategy at Bridgeable, who will share her thoughts on where we go from here. Over to you, Jordanos.
Great, thank you so much, Sonia, and thank you to all the wonderful panelists on the call today for sharing your experiences, leading all these social prescribing initiatives, along with your visions on how we can advance the health and well-being of Canadians in the years to come. And also thank you to all those in the room who shared some really great questions during that Q&A. I think everyone really benefited from hearing the panelists' responses to each of those. And as Sonia mentioned, my name is Jordanos, and I work at Bridgeable, and I'm very happy to share some closing remarks for this very informative and very timely panel. This summer, Bridgeable had the privilege of partnering with the Canadian Institute for Social Prescribing and the Canadian Social Prescribing Community at Practice through our 4-month-long internship program. So during this time, we had the opportunity to speak with social prescribing experts in BC, Alberta, and Ontario in order to better understand what these service delivery models look like across these regions. We spoke with physicians, link workers, community connectors, program leads, government stakeholders, and what stood out most to our team throughout this project was the collective excitement and momentum that there currently is around social prescribing. So the insights that we heard today from our panelists, again, are a huge testament to what this looks like, and really exciting to be hearing about these new and emerging initiatives around social prescribing. I'd like to share a quote we heard from Dr. Karen Kowski, who's the Executive Director of Sky to Seas Divisions of Family Practice out in Whistler, BC, who we connected with this summer. And the quote is, "The positives were not only better patient outcomes, but better provider satisfaction, because collectively we were able to accomplish things that at times would be crushing workloads. People were almost weirdly energetic and happy to be at work." So this quote is one of many that we heard that really captures the positive ripple effect that social prescribing can have not only on those who are receiving the services, but also on those individuals who are working on the front lines and delivering them. So I'm gonna ask that we pull up a slide for you now. And on the screen, you will notice that we've identified 5 early building blocks for advancing social prescribing in Canada. So these building blocks were a key output from our work this summer, and were intended to provide some early thought starters and areas of focus for advancing social prescribing at a national level. So these building blocks aim to not only support collaboration between multiple stakeholders, but again, support this momentum that we're currently seeing around social prescribing in Canada. So the building blocks that we developed throughout these engagements were, 1, to amplify the voices of social prescribing practitioners, as we're seeing here today. The second is to provide training and resources that can support link workers, as well as other social prescribing practitioners in doing their work meaningfully and effectively. And this includes providing trainings around health equity and how to engage effectively around anti-racism, anti-oppression, and ensuring that folks on the front line have these resources and trainings available to them to do this work well. The third was creating a friendly policy environment, so promoting some multi-sectoral collaboration around social prescribing, so really seeking to address social determinants of health across multiple ministries as an avenue to really support social prescribing at a national level. And the fourth is building bridges between healthcare and community services. So we heard this on the panel today, but really around focusing on building connections between healthcare and community services that are focusing on preventative care, and again, supporting alleviating the burden on our healthcare system. And lastly, measuring impact, which again, we heard about today on our call, that there's a lot of efforts that are being done to figure out how we can effectively measure impact of social prescribing initiatives. One of the things we also heard was the importance of capturing some of that qualitative data as being really important. I know Lisa mentioned that earlier on the panel as well. So finding ways to really measure the value of social prescribing moving forward. And I'll quickly, I know we're at almost time, Sonia, so I'm gonna just share another quote that we heard from Rob Miyashiro, who is the Executive Director at Lethbridge Senior Citizens Organization in Alberta. We had the pleasure of connecting a few times, and he shared with us this quote. So, "All these community services are really great ways of helping people stay in their homes, helping people have a rich social life, having people connected to their communities, and in the long run, it's definitely going to help their health outcomes." And with that, I'll hand it over to you, Sonia, to wrap us up.
Thank you, Jordanos. A huge thanks to all of our speakers for the insightful, inspiring conversation and the great questions from everyone. I have a message from the organizers and to thank everyone to participate in this conference up until now. The organizers are awarding 10 lucky winners with a free yoga class pass from the sponsor, Toronto Yoga Co. The names are being posted in the chat, so I guess you have to stay in the session chat to find out if you won, and a confirmation email will be sent to you. And they're also offering gift cards for Tim Hortons after the conference for those who complete evaluation surveys. So please do that. So on the screen here, if you want to get in touch with any of the presenters or want to learn more about what's happening across Canada, you can email us at cisp@retcross.ca and we will connect you. You can also visit the CISP website for resources, sign up to newsletters, check out the events page. And on the website, there is a map of all the social prescribing initiatives across Canada that I am aware of and that we collectively are aware of so far. But please use it to find out what's happening in your region. You can also contact us to add to the map if there's something that we're missing or if it's something new that you are starting. And if you have specific expertise in research, in policy, knowledge mobilization and training, you know someone or you are a clinical champion, you can join our communities of interest and be connected to like-minded people. And if you're an implementer, are thinking about implementation, but you're not yet connected to the fabulous national community of practice convened by the Alliance, OACAO, and United Way BC, please do so and be connected with peers. So I look forward to continue the conversation and growing this important work together with all of you. Merci. Thank you for your gift of time today. And I look forward to being inspired for the rest of the sessions today with all of you. Take care, everyone. Thank you.